Good morning, everyone. Bob Ravenscroft, Vice President for Advancement. It's Friday. As you can see, we have a couple of guests with us today. We have a ventilator and a BiPAP machine. There's been a lot of questions about the conversion of the BiPAPs into vents, and then people curious about what a vent actually looks like and so forth. So we have not only the BiPAP and the ventilators, but presenting a little bit later are Jason Rathbun and Holly Krieger. They are both proud graduates of Southeast Community College's excellent respiratory therapist program. Jason is an assistant manager in our respiratory therapy department, primarily works at the Bryan East campus, and he's been on the Bryan team for 21 years. Holly Krieger has been a registered respiratory therapist for 14 years, and she currently works in the emergency department on the Bryan West campus. So after we share some of the routine numbers and John makes some comments, we'll have Holly and Jason come up, and Holly's going to give the perspective of what it's like caring for a COVID patient, not only in the emergency department, but both of them have experience of dealing with isolation patients pre-COVID and during COVID. So I think it'll be an interesting perspective for you, and then you can learn a little bit about how these machines function. For the media, we will be doing some work afterwards and sending you some B-roll with Holly and Jason going through some specifics on the machine, so you can have that. Before we get to John, just real quickly, our midnight census was 363. The Easy Visit screening questionnaires for COVID-19 have risen to 8,718, resulting in 2,420 easy visits, and now 1,120 residents have used the COVID promo code, which waives the fees. Testing total, again, if you want the urgent care hospital and drive-through breakdown, just let us know. We'll just be presenting totals from here on out. Total number tested at Bryan locations is 1,237. We now have 53 positive test results. If you recall, last Friday it was 9. Negative test results are 1,030, and we have 153 results pending. So with that, before Jason and Holly come up, I'm going to invite John Woodrich, CEO of Bryan Medical Center.
Good morning. I wanted to break down some of those numbers a little bit further for you. So currently we have 5 positive COVID patients in-house, 4 from Lancaster County, 1 is from outside of Lancaster County. We have 13 other patients pending results, for a total of 18 patients. 4 of those patients are in our ICU unit, 4 are in our progressive care unit, and 10 are in our general care units. We still have 2 of the patients that are on ventilators. We have 29 people in our ICU in total. That includes all intensive care patients. I did want to share with folks, part of our surge plan as well is looking at how we could conserve our PPE equipment and give physicians access to COVID patients. So we have set up a telemedicine network within the hospital as well, so that we could have 50 beds to where physicians could be outside of the room and still seeing those patients and conversing with them. It's just another alternative and plan that we have to preserve our PPE, as well as keep our folks safe. So we will continue to roll that out as our surge continues and as we see more patients come in-house. With that, I'm going to turn it over to our respiratory therapist.
These are 2 of our machines that we use at Bryan. This is a ventilator. It is what we typically use to ventilate our patients. This is a non-invasive ventilator, normally we call it a BiPAP. Typically this is used with a mask. However, if the need were to arise, due to the software that is built into this machine, it can be used as an invasive ventilator. So that is an option for this one as well. It's not too terribly different than caring for anybody else. I mean, we have to take a little bit more care in our personal protective gear. We're still doing breathing treatments with them that we would do with any other patients that come in with respiratory problems. If a patient is in the need of a ventilator, we can run our breathing treatments through the ventilator. We can suction their lungs through the vent. We monitor their vitals a little more carefully when they are on a ventilator, as well as a BiPAP machine. You really have to just be good at making direct eye contact with your patients, speaking directly to them, let them know that you're there for them, whether it's reaching out and touching their hand, trying to smile at them through your mask. It really is your body language towards them is key when you are fully garbed up in all of your protective gear.
The biggest thing is kind of just reiterating the fact of what Holly stated, is the difference between a ventilator and non-invasive is dependent on what apparatus you have. An endotracheal tube is inserted into the trachea to help control the breathing, help control the rate of the breathing, the size of volumes that as these patients are dealing with, as they're going through this process, we can support or we can take full control depending on what is needed at that time. The BiPAP, and along with the software, usually a BiPAP is with a mask that allows the patient to be able to still communicate. They're able to sometimes come off of the BiPAP as far as to have that conversation with the nurse if they have questions, if their shortness of breath is relieved, if their oxygenation has recovered from their disease process. So as far as the software is built into our machines, our V60 machines, that once we have moved on from a mask and intubated the patient with an endotracheal tube, we then have to tell the software that there's less of a leak, there's going to be tighter pressures, and then change our alarms so that we're taking care of the patient properly and effectively.
Well, with the supplies on hand, we do not believe that we're going to be in a situation to warrant that type of gut-wrenching decisions, but if it should arise, we have an ethics committee comprised of physicians and clinicians that's been in place long before the pandemic to evaluate those type of decisions, and we would take guidance from the ethics committee. First of all, that's absolutely true. That's what the scripting would have said. Results are not typically taking that long. It's usually 2 to 3 days, but there were some early outliers in the testing process that extended up to 2 weeks, so that was the scripting. Things have kind of stabilized, so that scripting is being changed. So the person who called the radio station absolutely would have had that type of guidance given to them. Absolutely, we would continue to do it as needed, and they will be used as BiPAPs when they no longer need to be used as vents.
Currently, we have 2 COVID positive patients that are continuing to be on vents. One is on its 8th day, and the other one is, I believe, on its 5th day. They continue to stabilize. We're continuing to work with them, and we work well with the physicians and the nurses to try to decipher when the best time to wean those patients or get them a chance by waking them up off their sedation medication, along with breathing trials to see if they're strong or effective enough to maintain the control of their own breathing. Once again, there's a lot of information out there concerning treatment and stabilization of these types of patients that we're seeing. The physicians are still in the control of what is ordered and what is done to these patients receiving therapy. Physicians are keeping up to date with all these, so the high humidification, the proning we're already doing where we're moving the vent patient, we're moving them face down That helps with oxygenation. It helps with dependent areas of ventilation with the lungs to recruit new alveoli, which helps with oxygenation. So we're doing different things, but it's still under the supervision of a physician along with their orders. Our current patients are our COVID positive patients that have been on the ventilator the longest period of time at this point. All of the other patients who were suspected were either tested negative or they came off the ventilator, and I don't have that data on how many of the days, how long the days lasted. I know that prior to these two patients, most of our patients who were suspected or COVID were short days. Within 2 to 3 days, they were extubated and moved to a different area if they were negative.